Good morning, everybody. It is currently 11:15 a.m. on the East Coast of the United States. This is Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I am your host, Lisa Salberg, and I am joined today by Dr. Marty Maron, who has his casual lowercase Marty Maron on his name today, because we're here to just have a good conversation about things related to hypertrophic cardiomyopathy. Good morning, Marty, and Happy New Year.
Good to see you, Lisa. And welcome to everybody listening. And yes, Happy New Year 2026. We're ready to roll here.
Here we go.
Another big year coming up, right?
We're going to have a very busy year in the space of hypertrophic cardiomyopathy.
Did you do anything last year at all, or I'm joking?
So my last year was 6 countries I've traveled to, right. 17 states, and DC a number of times. I'm actually going to try to stay a little bit more grounded this year and do more work from here, because we've got a lot of amazing projects that are coming into focus this year. Our patient registry is starting to roll out. We've got our first e-consents handled this week, so that was a big milestone for us. And we've got some big projects that are coming up, not only for Heart Month and our annual meeting in October, but a patient-focused drug development meeting in February. We've got new discussion groups coming out. We've got a men's group, a genetics group. We've got more content to engage people in a more meaningful way and meet people from where they are and answer their questions and help them navigate life with hypertrophic cardiomyopathy. But I want to take a moment on this particular day to acknowledge what the day is. It is January 9th, and this would have been my sister Lori's, well, this is my sister Lori's birthday. She got 36 years with us here, and she would be 67 years old now. She would be retired. She would be a retired grandmother of 4, and she would be enjoying her grandchildren today, if not for her mismanaged HCM. So as we start 2026, it is also a milestone year for us. It is our 30th year of operation. And I will take just a moment to dive down a memory rabbit hole. And I believe in the other room, I probably should have gone and grabbed it. I actually have the note that I had called this guy because I was confused and I didn't understand what was going on with my sister's care or my family's care. And I found this article from this guy named Marty Maron, who I guess might have known something about hypertrophic cardiomyopathy. So I placed a call, and his secretary, Terry, answered the phone and said, "Who are you?" And I said, "This is who I am. I think I want to help patients get better educated or support them in some way. Can we talk?" And your dad was gracious with his time and his understanding of where I was in my personal journey and where HCM was in its journey. And that relationship really became the foundation of what we are doing today. So it's been 31 years since I've celebrated a birthday with my sister, 30 years that we've been doing the work of the HCMA to help ensure that other people's sisters don't die needlessly. And it's also the 3rd anniversary of the Lori Fund, and we have given away over $18,000 in travel scholarships to patients needing to get to HCMA Recognized Center of Excellence care. So we've got a lot to celebrate in our 30th year. We're living in a world that's a little chaotic right now. We can't fix the outside world, but we can make sure that your HCM care is as good as it can be. I know healthcare is changing and shifting, and we're going to be right there with you as it shifts and change to make sure that patients are first in healthcare. So, Marty, that's my recollections. And my acknowledgments of my beautiful sister and the legacy that she's leaving through what we're doing here today. So happy January 9th.
That's well said. Yep.
Yeah.
Very well said.
Okay, so as our new format of Tales from the Heart, I challenge our regular visitors to tell us some items of note since last we spoke. Now, we last spoke to Marty not too long ago because we made the announcement that Cytokinetics had gotten approval from the FDA for their new drug, Mycorrhiza, aficamten, for approval for obstructive HCM in the United States. Since then, Marty, what else have we learned?
That wasn't that long ago to start with, as you said. Yeah, I think it's as we talked about at that time. I mean, I think it's a really exciting time. I mean, I think it's I'll say just one thing. I mean, I think that one thing I think we really appreciate with the emergence of aficamten is that it's important to point out, I think, that one, it gives another treatment option here. And I think, I've been asked like what surprised me the most about that development. And I don't know if it surprised me, but I think one of the important points was that, the FDA, when they approved aficamten, I think when they did that, they, in a way, kind of validated or substantiated an important aspect of that drug, which is its safety. And they did that by recommending a REMS program. And again, we have a REMS program already, obviously with Camzyos, but we have a REMS program with aficamten, but that it looks different a little bit here. And I think the differences with that REMS program are important because they underscore the confidence, really, that the FDA had in the safety and tolerability, in particular, of aficamten, which really is so important, obviously, to patients and the providers, that we are giving medications that not only have high efficacy, making patients feel and function better, but they can accomplish that goal safely, And I think that REMS program with aficamten is underscored. That aspect of it is underscored by the FDA's implementation of one that's very flexible, a flexible, program there that will, I think, be very favorable for patients and providers, and I hope will really, create even greater engagement because of that as well.
I agree. I think myosin inhibitors are here to stay, and they have a very important role in HCM management for obstructive currently.
Yep.
And I think we've come a long way, and it's exciting to see targeted therapies for HCM and options for patients who have different profiles. Just because you're on one myosin inhibitor, like a beta blocker back in the day, like maybe one's not right for you, maybe another one is. And there are different pros and cons to your drug choices. And this is why it's critically important to meet with a specialist who understands the uniqueness of this disease state and your life course. One of the things I'm taken with on my Corso is the safe pregnancy. It is tolerable with pregnancy. And there are women of childbearing years who have been concerned about starting a myosin inhibitor because maybe they want to start a family. So I would encourage those conversations to continue and to really look at where all of your options are and make sure that you're getting the best care and taking advantage of all of the science we've worked really hard to create and bring to the community.
Yeah, no, that's exactly right. I mean, I think, when we talk about evolution and progression, in therapies, part of that is improvements in safety and tolerability and also ease of use. I mean, it's important that we can be able to provide a lot of components to, the increasing success of new therapies. But part of that is that patients can tolerate them very well and also can get access to them, of course. And then 3 is that they can do that, in a way that's easy for them, and not as least disruptive in a way to their life as possible. And I think what we're seeing with aficamten is an evolution in that as well. And I think that's something to be really excited about, obviously, particularly at the beginning of this new year, and looking forward to being able to implement that as we go forward here.
Absolutely. There was an article that dropped earlier this week from our friends at Imbria.
Right.
And for those who don't know, we have a clinical trial that we are helping recruit for Imbria in hypertrophic cardiomyopathy, non-obstructed. But they had another trial in heart failure with preserved ejection fraction. Can you go over some of those results that were published in the paper earlier this week and let us know what this mechanism is or this drug is?
Yeah, sure. For those that may not be familiar, in that maybe quite a few, because it's a new drug that's under investigation at the moment. It's not approved. It's under investigation, which means it's being evaluated in non-obstructive HCM right now as part of what we call a phase 2B study. and it's called the nirafaxtat. And it's really an interesting and novel therapy. It works by essentially altering the energy source that the heart, in this case, the HCM heart, uses and relies on for both contraction and relaxation. Okay. And why that's relevant and particularly important here is that in HCM, for a number of different reasons, the energy source that's usually used by the heart is an inefficient source. Okay, it's called free fatty acids, and by shifting, the drug then shifts the use of the energy from that to a different source, shifts it more preferentially to glucose, which gives the heart just a lot more energy. And that's important because the problem, and one of the major problems in HCM, particularly non-obstructive HCM, is that because the heart's thick, it's kind of stiff and it doesn't relax as well as it should. And part of the reason it doesn't relax as well as it should is because the relaxation part is really dependent on efficient energy source. And so by improving that through this drug, the idea is that you will help optimize the mechanics of the HCM heart to help it relax better, fill better, and that will translate into patients feeling better and functioning better. Okay. And then to connect that to what you just said, the nirafaxat, showed in non-obstructive HCM in a earlier study that was published already about a year ago, that it did, in fact, in symptomatic non-obstructive patients, make a significant portion of those patients feel and function better. And that led to the current effort, which is a phase 2b study called Fortitude, which is currently a global study looking at that drug in non-obstructive HCM that it just started enrolling in the US. Okay. And what you just mentioned was a study looking at that drug, nirafaxat, not in HCM, but in a different form of heart failure. And why that's relevant, and I think why you're talking about it, is that, there are other diseases like HCM, other heart diseases, where there is this energy deficiency problem that leads to patients not feeling well. And I think what this study showed was that when in those heart diseases, what we call heart failure, in the setting of the heart function being normal from diabetes and diabetes and obesity, so patients that had those plus heart failure, that the drug nirafaxat had an effect of optimizing the energy utilization, and that translated into improvements in the heart function and how patients felt and functioned, similar to that prior study in non-obstructive HCM. So it helps to kind of confirm, in a way, and support the findings so far that we've seen in HCM now in other heart diseases, for a common reason, that the energy problem, if you fix it, it may be very helpful for patients. So that's what that study showed, essentially. And so it gives more confidence and I think, enthusiasm to what we're doing with that drug in HCM now with that Fortitude HCM global study. And so if you're a non-obstructive patient out there and you're feeling frustrated by symptoms and your quality of life, then, as we've talked about before on multiple podcasts, considering exploring clinical trial efforts like this one, may be worth exploring with your local cardiologist.
I think that was a great setup, and I will let you all know that we did start our recruitment for Fortitude HCM back in November. We opened it up for the programs that were open. But we did take our foot off the gas intentionally because through the holiday seasons, not many people want to engage in a new clinical trial and start up during the holidays. So in another week or so, you're going to get a newsletter with the survey again with updates on what sites are open. And you can choose to give us your information. We will send it over to a clinical site coordinator who will then speak to you about the trial in much more detail and determine whether or not you want to participate in that trial. We are just kind of a gateway to help handshake people so they can find trials more efficiently. So you'll be getting the opportunity to participate in that clinical trial coming up very shortly. And there are multiple sites open throughout the country, including Lahey, where Dr. Maron practices. I do want to jump back to something I forgot to mention at the top of the podcast as it relates to healthcare access in the United States.
Mhm.
As many of you may be aware, yesterday the House voted 230 to 196 to extend the ACA tax credits. I'm going to just be very blunt here and tell you, I don't necessarily know that that is our end destination for fixing our healthcare crisis in the United States, but it is definitely something that we need to do while we work on the bigger questions of how are we going to create a sustainable system. So at this point, I would tell you the power lies in the Senate of the United States. Please contact your elected officials, your senators. If you don't know your senator's phone number, call the switchboard at the White House, or I'm not at the White House, at the Senate building, and they will transfer you to your elected official. We also encourage you to work on the state level as well to ensure that health plans are sustained within your state, because there are state regulations and federal regulations that we're working with here. But right now, the action is at the Senate. And the Senate needs to know we need a viable healthcare system in this country. And earlier today, I dropped another edition of Tales from the Heart, which is going to go under the branding for 2026 of deconstructing healthcare. Lisa went on a rant at the end of the year as ACA was coming to an end. And I've been talking to a lot of amazing people within the healthcare continuum, people who have run major healthcare companies, physicians, people who are running hospital systems. They're in trouble too. They don't know how to provide the resources to their constituency. We're all trying to figure out where it broke, why it broke, and what we need to do to really fix it. And there's a lot of nonsense out there that has just been added on to healthcare for political reasons. We're not going to talk about politics. We're going to talk about what healthcare should be and where the problems are and where we as citizens can get involved to make positive change. I'm not here to fight with anybody in deconstructing healthcare. We're here to understand, why do PBMs have so much power? What is a 340B and how is it impacting how your hospital is funded? You probably have no idea. And if you did, you'd want to talk to your elected officials about changing those systems to make them more fair and balanced. So that is going to be part of another, what I call, pillar of Tales from the Heart, and that will be called Deconstructing Healthcare. And I will be talking to a whole bunch of different types of people all year about different aspects of healthcare and hopefully getting to a core understanding of what we believe as a nation we need as a healthcare system and working collectively towards that, regardless of who you voted for or what your political ideation is. It's healthcare, it's not politics. And we need to have that conversation. So we'll be doing that through the year. And I encourage dialogue, not arguments, dialogue. So looking forward to building that out with you as well. So contact your elected officials and let them know that we need to fortify healthcare and then work on the changes that need to come. Okay. That took a half an hour to get through 15 minutes to get through all the opening stuff today. So Marty, our topic for the week or for the month is kind of like, it's a fresh year. Let's restart. What do we need to do for our hypertrophic cardiomyopathy management in the year? What do we need to do for our family? What are we doing about screenings? I know there are some challenges with funding right now for some families, but a patient with HCM, what do they need to be doing annually to make sure that their HCM stays in check and that we're on top of everything?
Yeah, I mean, I think, the principle there is that, we recommend for sure that, HCM patients, even ones that may perceive themselves to be doing fine or no different than our year, at least annually still see their HCM cardiologist and should still get usually an echocardiogram evaluation of how the heart is doing in terms of its structure and function. as well as other aspects of the heart, like the valves, et cetera. So that should be done along with an EKG, and also the possibility of more testing as well, depending on the circumstance of that patient. So, clearly yearly evaluations with hopefully with your HCM specialist, and that should generally include EKG and echo on almost every patient yearly to evaluate kind of where things are with the heart performance, and possibly other testing depending on what's going on. And of course, that it's really important to, of course, let your provider know if you feel that there may be a change in how you're doing, even one that you could potentially consider to be subtle, but different, and that can sometimes and often does take the form of feeling like, for example, you don't quite have as much energy with certain activities as you did before, or you're maybe a little bit more out of breath with activities than you were the year before. So things that could be cardiac related that may be a little bit different, even if they're subtle, are important, of course, to let your provider know about, because those could be small changes related to HCM that we would want to know about, of course, because we have opportunities to potentially change that if that was from HCM, okay, with treatment. So I think some of those are the key. I think those are some of the key points to consider for patients as they think about what they should be doing on a year-to-year basis right now.
How often should somebody get an event monitor, specifically if they do not have an implantable defibrillator?
Well, if you don't have a defibrillator, then the answer is that in general, it's usually yearly too, as well. For most patients, particularly younger, middle-aged patients, that may change. That frequency of yearly monitoring could change a little bit as patients, continue to be stable and enter, more advanced ages with HCM. We may do that less frequent, or not at all sometimes. But that's the general rule of thumb, is yearly along with the echo.
And as they get older, are we still using event monitoring to identify underlying atrial fibrillation that they may not be feeling, or are we moving away from that?
Yeah, I mean, I think for younger and middle-aged patients, for sure, the priority with monitoring is largely for detection of abnormal bottom chamber rhythms called non-sustained ventricular tachycardia, that could impact, if that was present, could impact the assessment of that patient's risk in the future of a life-threatening rhythm, since non-sustained ventricular tachycardia, fast, irregular bottom chamber rhythms detected on a monitor, are what we call risk, could be a risk factor for potentially future life-threatening rhythms. So that's largely why we do the ambulatory monitoring in younger middle-aged patients. When patients get older, the risk of sudden death decreases, but the risk of atrial fibrillation increases a little bit, even more. And so there may be more of an advantage for monitoring older patients with HCM to detect atrial fibrillation, irregular rhythm of the top chamber. Okay. But the indication to do that, to look for AFib in patients that don't have symptoms of AFib, that are younger or middle-aged, is controversial a little bit. There's no clear answer to whether that should be done routinely for AFib surveillance like we do it for non-sustained VT. But I think as patients get older, it's not unreasonable to do a yearly monitor as well for that reason, meaning AFib, as well. So I think that's kind of the way we look at the rationale behind monitoring for rhythms in HCM.
Wonderful. Frequency of MRI.
Well, frequency of MRI is that there should be one done for almost all patients, on the initial evaluation, for example, with their cardiologist or at an HCM center of excellence. And we do that to, help inform with the MRI on certain aspects of the HCM heart, like the amount of scarring, what we call fibrosis, which is not something that you can see and quantify with echo. So that's an MRI-based finding, and that's a finding that if it's there, depending on the circumstances, can as well impact the assessment of that patient's risk of future life-threatening rhythms. So that's why getting an MRI and assessing for fibrosis, at least initially, is an important part of that evaluation. Following that, for kind of the routine follow-up in patients that don't have ICDs, generally what we've said is that it's reasonable to consider repeating the MRI kind of on an every 3 to 5 year basis for young middle-aged patients, for the purpose of, again, reevaluating for scar at that point. Okay. So that's kind of generally, I think, what most people are doing out there in terms of when to repeat the MRI at 3 to 5 years.
Okay, so as a patient is sitting down today and they're like, okay, it's January, I got the year ahead of me, I do or don't have healthcare access at this moment, I need to get these things checked off. So we want them to have an EKG and an echo. Some of them might be moving to stress echoes as well, depending upon the findings of their baseline echo, correct?
Yeah, right.
So there could be a stress echo involved. There could be event monitoring. And depending upon the last time they had an MRI, the MRI may need to be repeated periodically. So they can assess, look at their health plan, look at their out-of-pockets, see when they can afford to do this throughout the year, and get it on the calendar and get it scheduled before there's worry, and make sure that you're keeping up on it. Additionally, I want to talk about the genetic testing. I'm very proud of something, Marty. I don't know if I explained this yet, maybe in the KCCQ meeting that we had the other day. For all of you who participated in our KCCQ questionnaire, thank you. There was about 600 of you who gave us feedback on that. You had to be in the registry to get that particular survey. But 75% of the HCMA patient registry has already had genetic testing. The yield is about 40% are finding an identifiable mutation, and the rest we still do not know about. But I was super proud that we're doing a great job of getting people within the HCM community to do their genetic testing, to know who else in their family might be at risk, and to potentially use that information for therapeutic purposes down the line. We can't do that now, except for PGD. But we've got really good follow-up on people getting their genetic testing, and I'm super happy about that. But for those who had variants of uncertain significance or no gene identified, how often should they be reevaluating genetic testing for those VUSs and unknowns?
Yeah. It's a good question. And, for those that may not quite understand, the context there, because it's a little confusing, is that, with genetic testing, the expectation for a lot of people is that it's, the results of doing genetic testing is sometimes a binary yes or no. You have a mutation, you don't have a mutation. And it's not really quite like that. There can be certainly patients that have a positive mutation identified with genetic testing, but there's also results that are what we call kind of more gray area. Okay? And those are what you mentioned called variants of uncertain significance, meaning that the patient with HCM had genetic testing and it showed that there was a mutation, or what we call a variant, same thing, but that it's not clear that change is causing their HCM. It could be, but it's not quite sure. Okay. Variant of uncertain significance. And sometimes what happens is that over time, after the test, for example, after that test was done, over time, other scientific evidence comes to light that helps to clarify that change as being disease causing. And so it goes from being a VUS, variant of uncertain significance, to being a pathogenic mutation. And sometimes even the opposite. Mutations that were thought to be disease causing can be, even downgraded to unsure, at certain points. And that's all because of new evidence in different forms that comes to light through tests and other studies and otherwise that help to inform on those prior classifications of the mutation. Okay. And so because of that, the recommendation is to reevaluate if you had a genetic test done in the past and it was a variant of uncertain significance or negative, you may want to revisit repeating the testing or accessing information through your provider that may tell you or give you some sense that mutation that prior VUS could have changed in its status, to repeating testing perhaps every couple of years, revisiting that. Okay. I think that's generally what we've said. I don't think there's an exact cutoff that you should, revisit your mutation or your genetic testing results at every 2 years, but every several years, it's worth asking your provider whether you think you should get retested or not.
Okay. So we've gone over the big stuff. Now let's pivot to our family members.
Okay.
Let's review the screening guidelines for children in families with hypertrophic cardiomyopathy and adults in families with hypertrophic cardiomyopathy. How do we screen these guys? And I'm going to tell you, my perspective has changed a bit in 2025 based on personal experience. And I'm not 100% in alignment with the guidelines in my personal experience right now. So I'm looking to see where we're going to go here. When do we start screening our little ones? When should we do it? It's a tricky question, actually.
Yeah. I think here's what I would say. I think in terms of screening, that the answer is that for sure, screening with echo and EKG should begin no later really than the beginning of puberty. Okay. And the option, in a way, which is reasonable to do, to begin screening, before that, if parents, feel strongly in a way that is information that they want to try to clarify, meaning screening to make sure that there's no HCM in that child with an echo pre-adolescence. It's reasonable to do it then. Okay. It's hard sometimes to do the echoes for infants and young kids. I mean, it's just difficult to do it for them. It's just challenging logistically. It's really hard on them. And the risk of the chances, I should say, of identifying HCM that early, unless there was some other clinical indication that there was something abnormal going on, is really low. And so I think it really does mean that you can feel, relatively comfortable waiting until that child was at least out of being an infant and could tolerate the exam, the echo reasonably well. At that point, you could do it at that point. What exact age that is. That could be 4, 5, 6, 7 years of age. I don't think you have to do it at birth, or as an infant. That's kind of how we look at it. Okay.
My deviation has come from the experience of having positive genetic test results early in life. And then out of an abundance of caution, let's just get a baseline screening and ta-da, it's already there early in life before the age of 4 or 5. So will there be negative consequences to that child in that timeline? Probably not. Is there a lot that we can do to treat and protect at that age? Well, there are some things we can do, and most of it's watchful waiting, right? We're just monitoring that child. But to those families who have come to me with the similar question of when do I screen my kids once I know they're gene positive, that's a conversation for you to have with your chosen healthcare providers. And I don't think it's unreasonable to screen them young and get at least baseline EKG and echo as soon as they're tolerable to do so, and to make sure that you're really having good conversations with your team about what the strategy is going to be and what you're going to do with positive or negative results. It's a very difficult time for families to live in the ambiguous nature of I have a gene, but I don't have a disease, and what might happen. So we know that this is a challenging space, and one of the reasons why we're starting a few new discussion groups this year, including a parents discussion group and a genetics discussion group. So we'll have places for you to have these conversations with your peers and bring that information back to your chosen healthcare team, and hopefully make the best decisions that you can make on how to screen your little ones in HCM. Can we transition now to the adult children? So you and I both know that we think that people are clear, and at 50 something years old, we can still pop up with diagnosis after somebody's been screened multiple times. How long do we continue to screen family members if they're in a family with HCM, gene known or unknown? What do we do for adulthood?
For adulthood, in general, what we've said is that you want to do your most sort of intensive echo evaluations to see if there is evidence of HCM by increased wall thickness during puberty, because that's the time that's most likely that a patient will, if they're going to, convert to having a clinical diagnosis of HCM. Okay. So essentially it's year and a half during puberty. And then at that point, at the end of puberty, maturation, physical maturation for that child, usually early 20s, we start to increase the frequency of the echoes to be more like every 3 to 5 years. Okay. Because there is a small chance that a patient could convert to HCM later in life. We call that delayed onset disease. And that's uncommon, but can happen. And so for that reason, we still extend the screening out beyond puberty every 3 to 5 years until about midlife, which is when we've sort of said at that point, if the echo and the EKG remain normal, that it's reasonable to stop at that point. Okay. And that there's no exact line in the sand there. I don't think. We've generally called it, mid to late 30s, 40s. If the echoes are normal, then I think it's reasonable to stop.
But we have seen them sneak in their 40s, 50s, and 60s when there is a family history. So it gets a little complicated.
I mean, I don't know. I mean, I would say that, I have to say that the amount of times I've seen somebody who you were following through their 20s and 30s with normal echoes convert to HCM in their 40s, 50s, and 60s is, extremely, extremely uncommon. Okay. Overall, as a numerator denominator issue, is extremely uncommon. Okay. It's not that it doesn't happen. I mean, there are always cases of that kind of thing, but for that reason, because it's so uncommon, to mandate that patients continue screening of echo and EKG into their 60s seems unreasonable.
But we do have family members who are diagnosed later. Ross, who is staff here as well, his mom was diagnosed with HCM not until her 70s. He was diagnosed in his 40s. So sometimes there's delays to diagnosis, and there's other issues going on.
But hold on, I think we got to be clear here. Yeah, I think we got to be clear here, because I think there's we're talking about two different things. I just want to be is that, yes, a lot of people get diagnosed with HCM in their 60s, 70s, and even 80s. That's when they came to clinical attention and got diagnosed. What we were talking about were screening strategies. right, where you've been following that patient with echoes and you know they didn't have HCM, those patients converting to HCM by echo in their 50s and 60s and 70s is, I think, really, really uncommon. Okay. Most of the patients who would say, oh, but I was diagnosed in my 50s or 60s, they would have had a diagnosis of HCM if an echo had been done in their 20s or 30s. Okay.
Correct.
But they were asymptomatic and there was no reason for a clinical diagnosis to be made probably in them at that time. So that's those are two different
sides of the coin.
Exactly. Just to be clear, because it is a little confusing.
Yeah, that's what I was trying to pull out of there. So diagnosis can come at any point. I've even had people 95 and greater who were diagnosed with HCM. So the diagnosis can come at any time, but family screenings, if you got a diagnosis, so Dave here just says he was diagnosed at 44. Common age to get diagnosed for HCM because you come up with symptoms. Now we take your family and we open it up and we look up, over, and down the family tree. Parents, siblings, children. And from the parents, you might go out to your aunts and uncles, then you may go out to your cousins once you start following the HCM through the family line. So now you have knowledge, Dave, and you can go get your family screened. And as they age out, maybe we clear them of diagnosis and it's not a problem for them. If they carry the gene, Marty, and they haven't developed yet, do you treat those a little bit differently than no gene identified, or do you continue to screen those ones?
You mean
later?
You mean in an offspring or a child who doesn't have the mutation, you mean?
In an adult who has a pathogenic mutation that runs in the family, but they're 50 and their heart's still normal.
Yeah.
Do we treat them a little bit differently?
I mean, you may want to consider extending out screening a little bit longer there, potentially, but there's no clear guidance there. I mean, I think we generally have considered them in the same way as, patients without a mutation. If the echo and EKG are normal at midlife, I think that for both sets of scenarios, I really do think that means the likelihood of developing disease after that is very, very low, very low.
Fantastic. Are there any other things patients with HCM should be thinking about when they're planning their 2026? I'm thinking about some clinical trials myself. Is this the year for you to consider clinical trial? And what might you want to do? What else might they think?
Yeah, no, I mean, I think that's right. I mean, that's a message we've been talking a lot about is that, if you are interested in contributing and potentially benefiting yourself, but also the broader community of HCM patients, then I think a clinical trial, opportunity is really, really important to consider. It's at least worth talking about with your cardiologist. You may not fit into a current protocol for a clinical trial at all, or that may not be something you're interested in, but at least exploring it first and seeing what options may be available for you, I think is a really reasonable part of the discussion you should have with your HCM cardiologist when you see them.
That is great. We have a question from Vicky about being diagnosed in her 70s and her children are in their 40s and 50s. So in this situation, if her kids got a screening at 48 and 51 and they're clear, that's one set of scenario. And if they get screened and we find something, well, we know what we were finding. Do you have any other guidance for Vicky?
Well, again, I mean, I don't want to be necessarily specific, here, but I think what Vicky's scenario raises is kind of what we were talking about before, is that this is a situation where there was no mutation identified, and her children are have essentially achieved midlife or close to it with normal echoes and EKGs. That would be a scenario where I think there's a lot of comfort there that likelihood of those children developing HCM is very, very low, so low that we would probably say there's no clear reason to continue screening.
Okay.
At those ages, unless, again, of course, what we say is no reason to continue systematic screening, with the caveat, of course, that if those children have a change in their status later on in life, obviously, with symptoms that develop or those kind of things, then obviously the appropriate testing should be done at that point. But routine screening can be probably discontinued.
And then we have a question, just to go over the guidelines again. For children, we're doing the screenings every year to 18 months, I guess is what the number, 12 to 18 months, for onset of puberty to full growth. And then every 3 to 5 years thereafter. When the cutoff point is depends upon the family story and the genetics and a couple of other variables. So Diane, I hope that is helpful. Marty, do you need to clarify anything there, or did I get that one?
Yeah, you got that right. Yeah.
Okay. So I want to acknowledge that there was a news story earlier, a couple weeks ago, about a patient in the South who was in the hospital about getting evaluated for a heart transplant. And on Christmas Day, his teenage daughter passed away while opening gifts. It is unclear. I've been asked this question from many people, and the story's been brought to me from many different angles. It is unclear whether the daughter also had hypertrophic cardiomyopathy, but we are likely to suspect that that is what is at play here. Our condolences go out to the family, and we are looking forward to speaking to them in the coming weeks to help them navigate their next steps with HCM as they are grieving the loss of their child. So again, an HCM family has made the news, and unfortunately not with a happy story right now. So I hope that we will connect with them shortly and provide them with additional resources. Willie's confused. Willie's confused. We have to help Willie not be confused before we leave, Marty. Bit confused for me because I had HCM, didn't have a positive genetic test, nor did any of my children. Okay, so again, it's very hard to get into specific cases with specific families and answer things in a podcast. But generally speaking, just because you didn't have a positive genetic test for HCM doesn't mean you don't actually have hypertrophic cardiomyopathy. We don't know all the genes that cause it yet. It's just you don't have an identifiable gene at this time. So your children need to be screened under the protocol that we spoke about earlier during, childhood and adolescence, and then adulthood in those systems every 3 to 5 years if they're adult children, annually or thereabouts if they're under 20, 25 years old, and they're not at full growth yet. So, Marty, you want to see if we can clarify for Willie a little bit more? I don't know what else I can say.
I think really the deal is clear that 70% of patients, 70 about, with a clinical diagnosis of HCM by the echo or MRI, have genetic testing that shows no mutation. That's because it doesn't mean they don't have HCM. They do. It just means that we don't yet know what the genetic change here is, and it's not on the panel then, and so it comes out as negative. Okay. And that means that it doesn't stay. So that, just to be clear, it doesn't mean that it still can't be genetic. It's just that the current panel that we know of doesn't reflect all the types of genetic changes that could cause HCM, because we're just not there yet to have a complete panel. Okay. So the kids should still be screened for HCM, just like we talked about at the frequency with echo and EKG that we talked about. But you're in the majority. That's what 70% of patients are like that. No mutation identified with HCM.
That's where we are. So Dave just recently found us, and we're answering his questions because that's what we're here to do. So Dave, we're happy to be here for you to do that. And we come to you weekly with our expert panels of physicians to answer your questions. We're here every Friday morning at 11 a.m. Eastern time. Coming up in the next year, we're also going to be doing a complete, think about Tales from the Heart in silos. This is one of the silos, and Marty and Steve will be here repeatedly, as will Alex DeFeria, to do a weekly talk with you all. And then we have some other people that are going to be coming in either monthly or quarterly. One path is going to be about pediatric HCM. So Dr. Jeff Tobin is coming out of retirement for us to help facilitate some of those conversations with some of his colleagues. And we have Deconstructing Healthcare coming forward. And we're also going to be working with our Center of Excellence partners who are publishing information and do short form podcasting on articles of interest as they drop in the publications. We have a question before we run away, Marty. Mary Lou has a question. Are myosin inhibitors an option? I have obstructive HCM. So let's look at the keywords here. Obstructive HCM, 71 years old. Oh, you had endocarditis. I'm sorry. I've had that. It's awful. You got mitral valve prolapse. You got some regurgitation, re-echoing in 2 months. Does an obstructive patient who is symptomatic have an option for a myosin inhibitor?
Yes.
Yes. Your answer is yes, Mary Lou. I feel for you on your endocarditis journey. I've been there. It's hard. I hope you're recovered now, and I hope you're doing well. And please speak to your Center of Excellence physicians about the role of myosin inhibitors in your management strategy. Okay, Marty, first podcast of the year. I think we knocked it out of the park. And I encourage you all to continue staying in touch with us here. We're here to answer your questions and provide some information and to help the journey with HCM just be a little bit easier for you and your family today and always. So again, happy birthday to my sister Lori. Is also my great Aunt Anne's birthday today. They were born on the same day, and I got to spend their shared last birthdays with them at a nursing home. My aunt passed away at 95. Lori was 36. So 95 was a tough year for 95 was a tough year for our family. But here we are today doing good work in their name and memory. So thank you for joining us today. We had a lot of participation. We love the energy. It helps the conversation flow. And we look forward to seeing you on the next edition of Tales from the Heart. Marty, thanks.
It's a great start to 2026. Thanks, Lisa, as always. Appreciate it. Great discussion and look forward to the next one. Thank you.
Absolutely. Thanks, everybody. Have a great day.